Hello, everyone. Welcome to Cracking Addiction. My name is Dr. Ferghal Armstrong, and we have with us today Dr. Manu Bhatnagar. Manu, I thought today we'd talk about the diagnostic criteria for ADHD. So, do you want to talk us through the kind of the top level ideas of how we actually diagnose this condition?
We use the DSM-5 criteria in
Hmm.
Australia, and I think previously we'd mentioned the American DSM and the European British ICD. Look, they're pretty similar in terms of diagnostic criteria, but it is a starting point, and it's something that I do as part of a clinical assessment. Takes an entire hour in and of itself, but it's not the definitive way to diagnose ADHD. It's the rule book of whether someone might have ADHD or not. But the first point of the criteria is um, how long you've had these symptoms. And I think something to really keep reminding patients is that it isn't something that can be acquired or has an acute onset. ADHD is something you were born with, probably. It probably first started symptoms in childhood or adolescent. If you're 31 or 32 now and you happen to be seeing me, it's just that this is when you're first getting the diagnosis. So part of the criteria is at least 6 months of duration in the adolescent period, and has been a pervasive part of someone's um, functioning. It's only just coming to attention now. So that's what we would call a retrospective diagnosis. But often you'd also find that someone has had a diagnosis when they're younger and they just stop treatment and they're seeing you again for a re-diagnosis as an adult.
Yeah. Now, to make a diagnosis you've got of ADHD, you talk about this early onset in childhood. Is there an absolute maximum age beyond which the presence of these symptoms no longer can be considered neurodevelopmental?
I think it's more commonly seen under 12. 12 to
Yeah.
16, it's still seen. The hyperactivity subtype, so kids who are fidgeting or have a lot of agitation, disruptive, yelling, they're obviously picked up much earlier, and that's in primary school. And luckily, primary schools are a really important part of the diagnostic criteria being met because you can get that objective opinion about whether all of these criteria are demonstrated somewhere. A child will not, in and of themselves, be able to self-report some of these. So the hyperactivity subtype is often seen a lot earlier, and the inattention, that subtype can be little bit late to pick up. For some people, so late they're past the point where they can get a diagnostic assessment as a child.
So really what I'm hearing is that 12, you really want to have symptoms presenting before 12, and it's really for at least 6 months.
Yeah, yeah. And look,
Yeah.
I think if you do have parents and teachers who can do assessments earlier on, then that's under 6 even is probably the best time to be able to
Mm.
correct things. But yeah,
Yeah.
12 is
Yeah.
sort of an average cutoff.
So, Manu, you've spoken about how important it is to get a collateral history from primary school. So that brings us into a discussion on the concept of domains. So we know that to make the diagnosis, you need to have a certain number of criteria, but they have to apply in more than one setting, don't they?
Yeah, that's right. So um, people can have different set of symptoms depending on where they are, and the structure one gets in one particular environment like school can perhaps sometimes override those symptoms, whereas at home that structure doesn't exist and can be very disruptive. um, whether you're with a strict parent or whether you're in an environment like with your peers where there are no guidelines, it can really impact your functioning. What meets the criteria for ADHD is that these pervasive symptoms happen in multiple domains. So the DSM criteria says for more than two, but really you want to make sure that this is really happening regardless of where someone is and that it's affecting their functioning in academic, social, and also in terms of their hobbies in many, many different facets of their life. And it's impeding functioning to the point where they really can't succeed in any of those.
Yeah. So we're talking about school, home, hobbies, and in adults, I suppose the domains expand, don't they?
Yeah, I mean, you have more domains, but to meet the criteria, it's only more than two. So
Yeah.
you can direct
Yeah.
your question to
Mm.
two or more.
So we've got the need for symptoms appearing for at least 6 months under the age of 12. We've got multiple domains, and that can include school. We've also got specific exclusion criteria according to DSM-5, haven't we?
Yeah, and there's always a caveat in every disorder in the DSM, and it often says that this um, cannot be excluded by other disorders such as substance use disorders, mood disorders, or other uh, psychotic disorders like schizophrenia or
Yeah,
schizophrenia. And
yeah,
bipolar affective disorder can often mimic inattention and ADHD. So that's a common one that people can find into episode that they feel like they have inattention, but that's actually one of the symptoms of bipolar in and of itself. So making sure that you
yeah,
do a good history before embarking upon an ADHD diagnosis to include those is really vital.
yeah. Now let's talk about the specific sets of criteria. So we've got, broadly speaking, two classes. What are they?
So the two classes of symptoms are also the two subtypes of ADHD, which is
Hmm.
inattention, hyperactivity or
Yeah,
impulsivity,
yeah,
and have each of their own sub symptoms.
yeah. And how many? So I suppose we'll talk about kids first and then adults. So according to DSM-5, at least, how many symptoms do you need in each of these classes to make a diagnosis in kids versus adults?
So with kids, you need 6 out of the 9
Yeah,
symptoms to reach the
yeah,
threshold of having the diagnosis. And with
mm,
adults, it's 5 out of the 9 symptoms. But this is
yeah,
where it gets a bit tricky because having that collateral history going back in time to say you had all these symptoms, you need to have a parent or school reports or some sort of objective way of saying you had more symptoms when you were a child. But 5 for an adult is enough to meet the threshold.
Okay, so I suppose really it's time to drill down into these symptoms. So I have a mnemonic that I use to kind of try and remember the symptoms of both the inattentive and the hyperactive impulsivity criteria. So if we look at the inattentive subtype, my mnemonic for that is calf moved. So CALFMOVED. So the calf wasn't paying attention and moved away from the rest of the herd. That's how I think about it. So C for completion. So the inability to follow through projects. A for avoids homework or other large projects. L for loses things all the time. F for being forgetful. M, the minutiae of life, so the inattention to detail. O for organization, so poor organization. V for vigilance, difficulty in sustaining attention. E for ears, the symptom of, oh, he doesn't listen or she doesn't listen. And D for distractibility. So that's how I think about the criteria. But how would you approach the inattentive criteria
Well,
for
I'll
ADHD?
approach it with a calf moving. That's a brilliant change.
Well, you ain't heard nothing yet. Wait till you hear the other one.
Um, the way of approaching a history for this is there's a bit of an art in how you ask these questions.
Mm,
Someone will look up the symptoms of ADHD before they're coming to you to get an assessment for ADHD. I think it's
yeah,
goes
yeah,
without saying. So
yeah,
um, this is where those symptoms in and of themselves can't be how you make your diagnosis. You need to enter a discussion about what's going on for that person in their life and sort of
exactly. Yeah,
weave through crises or mood disorders or all the other things that could be happening that account for these symptoms, and then also ask them to give specific examples of why they perceive inattention. And then by the end of that, if you're not, oh yeah, I've got 3 or 4, then you can specifically ask, hey, by the way, do you spend a lot of time looking for your keys around the house? How
yeah,
how long does it take you to finish a task that you really want to do? So generally, you want to get
mm,
these symptoms from a natural conversation so that you can assess
yes,
any
yeah,
of them and then
yeah,
drill into the tick boxy
yeah.
elements.
One of the specific symptoms that I think is quite sensitive is this idea that patients will often start multiple projects before they finish the previous project, and they're always moving to and fro different projects. especially in adults. They've got this desire to acquire everything or to meet all their goals all at once, and they don't seem to have the ability to actually sequence their goal setting. Yeah, it's almost like the blunderbuss bus approach.
Yeah, and I think a lot of people can relate to that. I can definitely relate to having a lot of moments where I'm inspired by something and I really want to do that, and then it doesn't pan out. I think the key with ADHD is that these aren't um, additional things that someone wants to do to potentially have side jobs or research something in their spare time. These are core ways of functioning. Basic homework that they need to do or study to pass an exam. Um, Writing an email to basically be able to pay your bills function. You start many things that you really need to do. They're really important, but you just never get
Yeah,
around to it.
it's not a choice, to actually, survive and function in life. This, as you say, is necessary. Here's a question for you: is it possible to pass an exam and do well in an exam with ADHD?
I think so. And I think the context of that exam is really important. So a lot of people who are doing exams, if they're part of a structured course where they have peers who are studying in pin drop silence, um, they can generally do the same thing in that really, really intense environment.
Mm,
Really supportive high schools, or maybe even strict, what one might say, could be conducive
mm,
to having someone
yeah.
with ADHD get through. Because ADHD says nothing
Mm,
about intelligence. It says nothing about raw
yes.
skills. It's
Yeah.
about being able to sit there and give
Mm,
focus to those things. So
yeah.
if something is there keeping you on track, then it is definitely possible.
I mean, I suppose this leads on to an idea or to a discussion, perhaps for another episode, about the idea of actually goal setting and ultradian rhythms and ultradian cycles, and how long it is actually possible for a normal,
Yeah.
sorry, not the word normal, but someone even without ADHD to maintain vigilance to study, and how can you adapt those routines to help people with ADHD? And that speaks to the vigilance, this difficulty in sustaining attention. I mean, what do a lot of people use this music that they wear headphones and they listen to specific binaural beats to help them focus. Do you think that's any good, or is that just a thing that some people might benefit from, others don't? Is that a real thing?
Yeah, I think there is an adequate amount of stimulation because people with ADHD struggle to focus when they have too many distractions. I think and sort of an optimum amount of background noise and stimulation is probably good to be able to set tasks and complete them. Um,
Mm,
think that neurodivergence with ADHD is a really important thing to keep coming back to because a lot of people with neurodivergence, be it ASD or ADHD, find that their sensorium is different. It's not just about the sort of why they don't function. And one of the good things about ADHD is that when you do have treatment with medication, you can find your own way of making that work. You can take the medication at a particular time and get yourself in the right environment where you can be productive. And I think that's a really important part of treating ADHD. So I don't know about the specific evidence, but a lot of people will find their groove, so to say, where they can be most productive, and they might be a little bit of background music or the lighting at a particular um, intensity in the room.
so if we move on to the hyperactivity impulsivity symptoms, again we have a mnemonic. My mnemonic for this is damp flirts. So I have a specific visual image around that, which I'm not going to share with you. But anyway, D, D for driven. A, answers out, blurts out answers. M, moving, always on the move, always on the go. P for play, cannot play quietly. F for fidgeting. L for loquacious, i.e., overly talkative. I for interruptions, so frequently interrupting conversations or finishing people's sentences. R for running inappropriately. T for turns, the inability or difficulty in waiting in line or taking turns. And then S for the seat, i.e., leaving the seat, often not able to sit still for any prolonged period of time. How would you approach these kind of movement symptoms?
That's a much more difficult one to diagnose in a clinical interview because someone, even when they do have the hyperactive subtype, in the context of an interview, a clinical interview, they can stop that for an hour. And four of the symptoms you mentioned are about verbal impulsivity, and that
Yeah,
can
yeah,
be
yeah,
difficult to quantify by assessing someone. It's, when you're asking a lot of questions and expecting a particular answer, it's really difficult to know how someone behaves in a natural environment. And then a
yeah.
self-rated question. I was like, did you do this a lot? If someone really wants an ADHD diagnosis, they're going to say, yeah, I do that all the time. So hyperactivity, firstly, isn't something that I'm seeing a lot in the people who are coming and wanting a new diagnosis, but it's definitely something that other people will pick up on and be disrupted by, especially in childhood, adolescence. So again, a natural history of saying, what makes you think you're hyperactive, and people will have to give specific examples, 2 or 3, getting their parents on the phone or in the room, seeing school reports, if they're still available, and saying Jimmy was interrupting a lot and talking to other students while it was quiet time. Those things can be telltale signs of it, but it's really difficult to diagnose that subtype in a clinical interview.
Certainly in adults, isn't it? But in kids, it's actually quite easy because they're the ones that break the furniture.
Yeah,
Yeah.
yeah.
So it's interesting how it's easy in kids, but difficult in adults.
Yeah, definitely. And I think a lot of the work with kids is watching them through a one-sided mirror and just coming to a diagnosis based on their behaviors and the patterns of play, as opposed to the words.
Yeah.
Because
So what does that look like then?
so that often will look like someone whose task is to set up some education for a child, and you're observing with a parent or someone else through a mirror, and being able to observe whether they can start a task that you've assigned them and then finish it. So basically, you're basically creating an environment that mimics where the disruption might be occurring, be it in the home or a school, and
Mm.
setting tasks and seeing if they can track through it, but also taking note of the motor symptoms in that environment. Because, like I said, even a child with a hyperactive subtype, they might be fidgety, but they can maybe keep it together for an hour in a clinical interview. But if there's a
Mm.
lot of stimulation in a room and there's lots of toys and then maybe one other kid, then the hyperactivity really surfaces. So
Yeah.
observing,
Yeah.
talking is sometimes more important.
Mm. Yeah. And have you got any specific triggers to think about this diagnosis in adults in terms of hyperactivity or impulsivity? Is there anything specifically that you rely on?
Well, I can tell you what's not part of the symptoms. I think something I keep coming back to is that people will tell me what their symptoms are, and I'll have to either debunk it or say, yeah, that's true, and come back to
Yeah.
it. So one of the things that it isn't is someone came to me and said, I think I do have ADHD and the inattentive subtype, because while I'm trying to watch a movie on Netflix, I keep taking my phone out and scrolling through Facebook, and I just can't focus. And the pop sensation that is ADHD with TikTok and social media is making it a very familiar and relatable diagnosis. And hey, there's a medication, a pill that you can take every day for it. So it's a very attractive thing for someone to live with, and it's also a very destigmatized thing. Like, we've done great in destigmatizing it, but the downside of that is it's a very attractive diagnosis to have at the moment. Um, my hunch with ADHD is often, you know, in the course of a natural history where someone's talking about how they're not functioning, picking up on cues where uh, they have legitimately tried and not really succeeded in many different domains of their occupation. Like, they start a degree and then they don't finish up. They try to apply themselves, and they're clearly intelligent or gifted in one particular facet of their life, but they just haven't been able to go all the way. And there's an unexplained um, firing or an unexplained issue at work that gets them to be kicked out. Relationships never work out because they don't communicate effectively. It's that first criteria of this being so dysfunctional to the functional, like dysfunctional to different settings in social or work, that really gives me the clue that this is probably ADHD that's gone under the radar. And the symptoms
Mm.
are sort of something that comes later.
Manu, on that sweet note, we're going to have to call it. I want to thank you again for your wisdom, and I look forward to chatting with you again very soon. So thank you.
All right, see you soon, Ferghal.
That's all for today, folks. My name is Dr. Ferghal Armstrong, and this has been Cracking Addiction.